Hello, my name is Jeff Sparks in Boston, Massachusetts, an ACR ambassador, and I'm happy to get the opportunity to report for Room Now as well. I'm here with my good friend, Dr. Janet Pope, and we're going to talk about rheumatoid arthritis risk factors and early RA, two of our favorite topics.
Yeah, hi, Jeff.
Hi. So I think we want to mostly focus this on two of our data sets that we do a lot of our studies in. Some of mine are in the nurses' health studies, and yours are in CATCH. So I wonder if you could just tell people about CATCH first.
Absolutely. So the CATCH cohort is an incident cohort of suspected or proven early rheumatoid arthritis. So symptom onset a year or less with proper suspicion of RA. And we have about 4,000 patients. And sometimes we have less because we migrated the database and asked different questions. But it's multi-site throughout many provinces in Canada. And it's a rich data set that we collect data and the patients do as well. We do freeze serum at some sites as well.
Great. And I'll fill you in on the nurses' health studies again. So this is nationwide studies that started actually in 1976. So over 40 years of prospective follow-up. And there's actually two cohorts, Nurses 1 and Nurses 2, which was started in 1989. Each of them have about 120,000 women. So we got over 250,000 women who have had prospective follow-up for over 40 years. And we've been identifying incident rheumatic diseases, particularly rheumatoid arthritis and lupus within those cohorts. And one of the strengths is that there's really high follow-up. Patients, people, they're not patients yet necessarily. Nurses are really, follow up with all their questionnaires. So we're able to answer, what things happen prospectively prior to disease onset. So it's been a real wealth of information.
And I think that's a real strength that you actually have factors that truly predate symptom onset, because I know you've looked at depression, you've looked at, and others in your team and group have looked at healthy living. Can you tell me about some of those things?
Sure. So we have some abstracts this ACR 20 to talk about. Some of these, I'm a co-author on all of these, I'll say. The first one that we were excited about is related to passive smoking. As you probably know, inhalants are thought to be really important in RA pathogenesis. And in the nurses' health study 2, they really asked about passive smoking throughout the entire life course. So this was analysis that was led by me and an instructor in medicine, Dr. Kazuki Yoshida. And we really looked to see whether there was an important time in life when passive smoking might impact rheumatoid arthritis. So we looked at maternal smoking. So when the nurse is actually in the womb, we looked at passive smoking as a childhood, looking at whether they lived with a parent. And then we also looked at passive smoking throughout adulthood, living with other smokers. And what we found is that there was a pretty specific association of passive smoking in childhood to predispose to later adult onset seropositive rheumatoid arthritis. And our speculation is that this could sort of be the first trigger, put epigenetic changes perhaps that might set up patients to have develop rheumatoid arthritis in the future. So some other abstracts that we're pretty excited about are related to lifestyle. So we're also interested to see whether lifestyle factors affect RA risk. And again, these factors have been collected, for many years prior to the clinical onset. So there were two sets of analyses that are presented at this meeting. The first is related to RA, which is being led by Dr. Jill Hahn. And really what we're looking at is 5 particular health behaviors: obesity, diet, smoking, physical activity, alcohol consumption, and whether this is related to incident RA risk. And what we found is that those who are really healthy do seem to have a much lower risk of rheumatoid arthritis. In a similar analysis that was led by Dr. Mei Choi, she looked to see whether these factors were related to systemic lupus onset. And this one actually was particularly associated, where these factors could really explain up to 50% of lupus risk, which is really quite impressive. So I think it really emphasizes that healthy lifestyle could have some alterations in the immune system, systemic inflammation, and really is quite important from a public health standpoint.
Yes, and it seemed like it was explaining maybe one third of the risk of RA too. So I think the take home is we
Right.
can drink alcohol if that suits you and you're not against that for other reasons. That we need to exercise regularly. That the Mediterranean diet's good, not smoking, and then things that weren't really looked at. I guess avoiding stress and all that would be helpful, and
Mhm.
probably not living with a smoker and choosing your parents wisely so that they don't smoke, and maybe choosing them because genetic risk is still there.
Yeah. It's all nature and nurture, but
That's
anything
right.
we can modify to improve does
Is
seem
well
to
worth
be
it.
important.
That's right. And it just links in with all the comorbidities or multimorbidities that our patients might have too. If you have some of these lifestyle features that are for the better, again, probably never too late because
Hmm.
certainly some studies show that a Mediterranean diet, exercise, and weight loss can help things like psoriasis and psoriatic arthritis, and a little bit of data emerging in RA as well. So there's a lot of linkages with we are what we eat and what the environment is.
So I
So
know a lot of catches related to, early RA, particularly remission. I wonder how you think about how these factors relate to some patient-reported outcomes that might affect patients' chances to get into remission.
right. So we have found indeed that remission is less if you're overweight, and the least amount if you're obese. Time to remission, it takes longer. The proportion in remission or less, and sustained remission is less as well. The other thing is we're presenting that even people in remission, irrespective of lifestyle, sustained remission is very difficult to achieve. And over the next 2 years, a large proportion of those who are in remission at one point in time aren't still there a couple of years later, which I think talks about the evolution of RA and drug resistance and possibly adherence and lifestyle factors too. We have to really disentangle why each individual might be losing their remission.
What's really fascinating when you think about what all your patient has gone through once they come to see you in clinic, and it's not necessarily just about the drug you pick, and there's really a lot that goes into how they're going to do and how they're going to perceive things. So really a lot more to disentangle, if you will.
That's right. I think for research, and I think some of the clinical take homes are that it's so important that patients feel that you're listening to them. There's some care gap pathway issues that are going on. That if a patient is more apt to be adherent, if they buy in, if they tolerate the meds, and if they think that you're actually listening and have their best interests at heart. So you're right. There's so many things that go into our art or our practice of medicine, and someday practice will make perfect.
All right, Jen, I think we could talk forever about this, so we'll spare the viewers anymore. Thanks again to the Room Now viewers, and hope everyone's having a great meeting. Thanks again.
Thank you.